Good morning. We're going to get started now. My name, for those of you who don't know me, I'm Dr. Sam Daniel. I'm here filling in this morning for Dr. Samuel Seward. We're very happy to have Dr. Sean Lee invite Dr. Elliot Tapper here today to speak on a very important topic. As many of you are aware, more and more people with compensated cirrhosis are living today. Therefore, they are exposed to the decompensation of cirrhosis, and hepatic encephalopathy is one that is most important. And today, Dr. Elliot Tapper is going to be talking about hepatic encephalopathy in 2019, flipping the script. Now, I don't have enough time to really do justice to Dr. Tapper's long, extensive curriculum vitae, but I'll try my best to give you some information on Dr. Tapper. I believe that Dr. Tapper completed his medical degree at Emory School of Medicine and his residency in internal medicine training at Beth Israel Deaconess Harvard Medical School. He then went on to do a combined fellowship, clinical and research fellowship in gastroenterology and transplant hepatology at the same institution. Dr. Tapper also did a certificate course on clinical effectiveness, something that's very important in research. And today, he also did that at the Harvard School of Public Health. He is currently an assistant professor of medicine at the University of Michigan and is on the faculty and staff physician of the University Hospital of Michigan and the Veterans Hospital in Michigan. Dr. Tapper's research interest has been in hepatic encephalopathy, and he has also done extensive work in quality improvement outcomes. He currently has R01 grants with the NIH and NIDDK. He has received many honors and awards over the years and written extensively in the gastroenterology and hepatology literature. One award that is very important to mention is the Stanley Rosenberg Award for Achievement in Quality Improvement Research, which he achieved in 2016. He is a reviewer of many gastroenterology and hepatology journals and is on the editorial board of many journals, including Journal of Hepatology and Hepatology Communication. We are very happy to have him here and very honored that he would come to speak to us. Welcome, Dr. Tapper.
Okay, well, thank you for that very kind introduction. Here are my conflicts of interest. So over the next 40 minutes or so, I have many tasks at hand, so many scripts to flip. I'm going to tell you about how the public health impact, the footprint of hepatic encephalopathy is actually quite outsized. I'm going to review for you to treat patients with overt hepatic encephalopathy when they show up in our hospital as an entree to discussing exactly where that HE is coming from so that we can refine our understanding potentially to target additional therapies. We're going to dispense with the old school thought of low protein diet, and once we're done talking about all of the bad things that could happen to patients with cirrhosis and HE, we'll start to think a little bit about how we ought to prevent those complications from occurring in the first place. So to orient us to the task at hand, here is a seminal paper from Spain. A survival curve here presents exactly what happens to patients that present to the emergency room with their first episode of overt hepatic encephalopathy. And by overt, I mean lethargy, asterixis, somnolence, even coma. And what you can see is the dismal statistic that barely 4 in 10 patients will be alive at 12 months. And yet, they're not dying because of HE, but rather that HE is a biomarker of all of the bad things that can happen to patients with cirrhosis: bleeding, infections, falls, and repeated hospitalizations. Those hospitalizations are occurring more and more frequently, on the order of 55,000 for the primary diagnosis of hepatic encephalopathy in 2014, the last year for which we had complete data. And because HE implies so many bad things about these patients' health, those hospitalizations are incredibly complex. And so the grand total that we're spending simply on those hospitalizations for HE alone is roughly 2/3 of $1 billion. Patients with cirrhosis are frequently hospitalized. And once they're hospitalized, it's far from the end of the story. They enter into what I call the revolving door of rehospitalization. So patients with decompensated cirrhosis are likely to be readmitted within 30 days at a rate of something like 28.5% in a systematic review that I did. So when you look at this nationally representative survey of hospitalizations in New York State, California, Massachusetts, Mississippi, Washington, you can find that there's ways that we can potentially tease out the specific risk factors for rehospitalization at 30 and 90 days. And there is no factor more potent than the presence of hepatic encephalopathy. This is what defines high risk in our patients with cirrhosis. In addition to frequent hospitalizations, there are many other complications that can befall the patient with cirrhosis. And some of those are notable, like car accidents, but the most common trauma that happens to a patient with cirrhosis is falls. And upwards of 4 in 10 patients with cirrhosis will report a fall in the last 12 months. So we looked at all of the emergency room visits that were performed in the United States for all patients in the US, including hundreds of thousands with cirrhosis. And when they show up with a fall, the rate at which they report a severe injury, like intracranial hemorrhage, is 1%. A femur fracture, 11%. And if you compare patients with cirrhosis to all comers with a fall in American emergency rooms, they are much more likely to report those serious injuries. And if you compare them to someone else with an organ failure state like CHF, and those patients are much older and have many more comorbidities, patients with cirrhosis are significantly more likely to report severe injuries. When you look at patients with cirrhosis themselves and you ask, what is it about these people that is special, that is leading them towards these life-threatening injuries? There is no factor more potent than hepatic encephalopathy. So those are many of the bad things that can happen to people with HE. And as we start to think about what we can do, it's worth asking the question, where is this coming from? And there is no discussion about HE that is complete without mentioning the ammonia hypothesis. I think it's worth just taking a jog down memory lane as to where exactly our concept of the ammonia hypothesis comes from. And it comes from the work of a hepatobiliary surgeon who was quite famous in Boston named William McDermott, who at the time was at the Massachusetts General Hospital. So he was interested in surgical innovation. He had studied the ancient literature on surgical innovation. He was prepared when he took a patient with painless jaundice to the operating room. He met a pancreatic mass that had encased the portal vein. In order to resect this person's cancer in one stage, he would have to remove the main portal vein. Now, there was a procedure that was defined in the literature called the Eck fistula, where you can simply cut out that portal vein and smack the superior mesenteric vein right on the inferior vena cava. This allowed him to complete the surgery in one stage, sew the patient back up, and send him out to recover. So this anastomosis is actually the first vascular anastomosis ever described. Eck, who gave his name generously to this procedure, was a student of Pavlov. And like his mentor, he also experimented on dogs. So when he created this vascular anastomosis, he was proud to report that all of his dogs would often survive. But something very curious would happen to them as they recovered. As he fed them, particularly when he fed them a meal that had meat in it, he would notice the dogs acting super goofy, walking into walls, sometimes lapsing into coma. He would call this meat stupor. And over the ensuing 70 years between Eck's first description and McDermott's operation, many people hazarded several guesses as to where that meat stupor would come from, but nobody knew for certain. So McDermott was very proud. He published his case report. He's doing Eck fistula now. But that wasn't the end of the story for that patient. He started to come back to the hospital after several episodes of being quite agitated and sometimes falling asleep for days at home. Every time he'd come into the hospital, he would wake back up, be sent home, and then get readmitted. Perhaps that sounds familiar. So what McDermott did without the interference of an IRB is he parked his patient in the hospital and he began to study him. And he thought, what was it about meat that could potentially cause this stuporous reaction? He would feed the patient meat. He would see that they'd become confused. They'd wake up. He'd try it again. And in meat, there is protein. And when that protein encounters the brush border of our intestinal epithelium, it is cleaved into amino acids, and from those amino acids, ammonia. The same thing is happening with respect to bacterial reactions in the gut. So he thought perhaps that ammonia is circumventing the Cori cycle of the otherwise functional liver and being delivered directly to the periphery, and with it, the brain. So McDermott infused ammonium salts into the patient, reproduced meat stupor, and therefore gave us the ammonia hypothesis. And there are a few things that have come about that have solidified the concept of the ammonia hypothesis in our cognition. First is that we know that it causes brain damage, reversible brain damage. When that ammonia gets into the brain, it causes an upregulation of peripheral benzodiazepine type receptors in the neurons, creating a dominant inhibitory tone. So this tells us two things. One, you can see this on your physical exam. You ask a patient to hold up their hands, tell them to stop traffic, or grip your fingers as tight as they can. You'll see their hands flap, you'll see the grip let go, because the brain is constantly firing that inhibitory tone, which we know is coming from ammonia metabolic derangements. At the same time, your astrocytes are trying to help out as best they can by taking up that ammonia and converting it to glutamine. The problem is no one needs that much glutamine. And that glutamine becomes osmotically active, pulling in water, creating a low-grade cerebral swelling that results in significant cortical dysfunction. So we know that the brain pathology of hyperammonemia is real, and we know that experimentally going after ammonia production works. So until the 60s, the standard of care for hepatic encephalopathy was to starve these patients, particularly of protein. Because if you take away all protein, then there's very little ammonia being produced. The problem is you watch these people die before your very eyes, and as you'll see in slides to come, that's a terrible idea. So some enterprising Germans were aware of a non-absorbable disaccharide called lactulose. This doesn't get into our blood, but what it does is it creates additional bowel movements that are shown to reduce peripheral ammonia levels and theoretically flush that ammonia out. But these original investigators back in the 60s were aware that it's not simply the laxative effect of lactulose that we're going after. Because in fact, if you can get someone up to 3 bowel movements daily, reducing their ammonia, you may treat their hepatic coma. But if you switch out that lactulose for sorbitol and are able to continue those bowel movements unabated, that patient will then lapse back in to hepatic coma. So there is something in particular about the lactulose action that is greater than its laxative effect. So in this study in JCI, you can see that that other effect is the production of organic acids in the colon. So we can't metabolize lactulose, but our bacteria can. Not everyone's bacteria can, but most people's bacteria can. And even if you're not having loose stools on lactulose, you are still acidifying your colon. And if you are acidifying your colon, those extra protons can combine with the ammonia produced by protein metabolism, trap that molecule as ammonium, and in combination with the laxative effect, flush it right out. So that flushing effect is absolutely key, but that acidification is essential. So it often comes up on the wards that a very smart resident will tell me, I've read a randomized trial of colonoscopy prep for HE. Why aren't we doing this? So this is that study, the HELP study. It's actually pretty cool. randomized 2 groups of 25 people to receive either a waterfall of Go Lightly 4-liter colonoscopy prep or a little bit of lactulose TID. This was executed by a GI fellow at the time who was his own research coordinator, coming in at all hours of the night to do it. So his name is Bob Rahimi. I call him Bobby Hustle. So as you can tell from this graph, patients who received that 4 liters of Go Lightly, they woke up much faster, implying that the earlier that you can get a bowel movement out of a patient with overt encephalopathy, the better. But that's not the end of the story. And it doesn't mean that we should be switching out lactulose for Miralax, other forms of polyethylene glycol, because before Bobby was able to get to these patients, they had all received some lactulose in the emergency room. 84% received some. And remember, a little bit goes a long way. So as long as you are acidifying the stool and you are ensuring laxation immediately, then you can recover the patient quickly. So lactulose is the treatment of overt encephalopathy. There is nothing that can replace this. Polyethylene glycol, no. Rifaximin, no. Lactulose is the go-to drug. But what is the right dose? So you have to think along the lines of the HELP trial that there are 2 different ways to write that order. One, what I call an induction dose, initiates that first bowel movement to clear the junk out. And then you can go back to that reflexive order of lactulose TID. So I learned as an intern that there were some nurses who were independently giving extra doses of lactulose to patients on the ward, and I would see anecdotally that they would wake up. We took what they did, we codified it as an order within the electronic medical record, and we found that we were able to significantly reduce the length of stay for overt HE. And in fact, patients who receive greater than 6 cups of 20 grams of lactulose within the first 24 hours are staying 2.4 fewer days on average, adjusting for a grade of encephalopathy, MELD score, even the hepatologist that's being consulted or taking care of them. So where does ammonia come from? And getting at a little bit about why the ammonia hypothesis isn't the whole story. So this is a picture that I published in Mayo Clinic Proceedings, and it's literally a stick drawing where the liver is a triangle that I got from Google Images. So I just want you to keep this in mind, that there's no level of cartoon talent that is required to publish papers in major journals. But the main thing here is that, of course, ammonia is coming from the gut, just like McDermott knew, just like Eck knew. But when that ammonia is being delivered through portosystemic shunting to the rest of the body, we are lucky to have auxiliary mechanisms in place to make sure that we're not simply bathing our brains in an injurious toxin. The kidneys play a very important role, but the most important role, in fact, 50% of the ammonia delivered to the periphery is handled by striated muscle. When your muscle encounters a molecule of ammonia, it efficiently takes it and combines it with glutamate to form glutamine. And that helps us detoxify the blood. The muscle is like a filter. The problem is that it comes at a cost. Your muscle must catabolize itself to produce the alpha-ketoglutarate that makes that glutamate. So you are breaking down branched-chain amino acids like isoleucine to detoxify ammonia. For every single piece of ammonia, there's an amino acid that must be sacrificed. So patients who are constantly experiencing hyperammonemia are at risk for sarcopenia. The less muscle you have, the higher your level of peripheral ammonia. The less muscle you have, the higher the likelihood of developing hepatic encephalopathy. So we're also increasingly aware in the field of cirrhosis and liver transplantation that frailty is associated with adverse outcomes. And we found that ourselves in a prospective study where we enrolled every patient who was coming through our clinic for transplant evaluation, and we administered a battery of tests known as the Fried Frailty Index. So we're asking them to show us what their hand grip is and how fast they can walk, and we ask them if they're able to rake the leaves and so forth. And when a patient is frail, they're much less likely to survive or receive a liver transplant. The problem is, where is that frailty coming from? Frailty is a secondary process, an epiphenomenon of hepatic encephalopathy for patients with HE and hyperammonemia. So think about it like this. Your liver is sick, it's all jacked up, you're likely to get hepatic encephalopathy. Once you get HE, you're not very happy. You have decreased appetite. You're becoming progressively malnourished. Patients with cirrhosis are already food insecure, and now they're much less likely to want to eat. The ammonia itself is rotting the muscles. They're malnourished. They become progressively sarcopenic. Their levels of ammonia rise. They become even more immobile. They are just sitting around in their recliners. This is where frailty comes from for patients with hepatic encephalopathy. And so what we found is that while frailty is predictive of adverse outcomes, it is not in patients with hepatic encephalopathy, because frailty is simply a secondary process after that hyperammonemia and confusion. And so for this reason, our societies recommend that we do not starve patients with hepatic encephalopathy. It is true that if you eat a steak in the setting of cirrhosis and varices, your ammonia level will rise. But over time, your ability to compensate for that hyperammonemia declines as your muscle stores are diminished. So we recommend that everyone has 1 gram per kilogram protein each and every day. Where is that going to come from? One of these days, I will report a conflict of interest from Dannon or Chobani, because I'm pushing this as hard as I can. You're trying to find ways to squeeze in protein in stuff that's delicious and flavored like strawberries or lemon meringue. And I am always recommending Greek yogurt. It's also about the timing. So it turns out that if your liver's all shriveled and useless, it's not able to do some of the critical metabolic pathways on which our body relies. One of those is producing the sugar that your brain needs to function and dream about all the great things that you're going to do on rounds today. So when I'm sleeping and I am fasting, but my liver is making sugar, my brain is happy. But when a cirrhotic patient is fasting, they cannot make that sugar. So your body turns to what is the next easiest source of glucose, and that is protein catabolism. A patient with cirrhosis must receive a nighttime snack, preferably something with protein, Greek yogurt, ensure a peanut butter sandwich, and if they do not experience increased risk of encephalopathy. They do not experience rehospitalization, but they are much more likely to increase their total body protein over the course of a year, as was shown in this landmark randomized trial. But ammonia is not the whole story, like I was insinuating, and there's a couple of lines of evidence to support that thought. One, going back to 1963, this single author paper by a guy named Jules Stahl showed that when you stuck a patient's vein or artery at the time that they had either no HE, grade 1 HE, or a coma, there's no level of ammonia that can distinguish those various grades. So ammonia is not helpful in figuring out the clinical syndrome of hepatic encephalopathy, something which was later repeated 40 years by an American group, where they showed that while there's a subtle trend towards higher levels and higher grades of encephalopathy, there's no one level that's going to prove helpful. And people who are showing up in full-on coma, who will wake up after administration of lactulose, 5% of those people will have stone-cold normal ammonia levels. But on top of that, there's another critical component that's missing from this story, which was best described by a paper by Shawcross out of the UK. So this is an investigator who gave Cipro to a bunch of patients with cirrhosis and a history of hepatic encephalopathy. Now, Cipro is a broadly active antibiotic, and it reduces a lot of the bacteria in the gut. And because of portosystemic shunting and gut barrier epithelial disruption, a lot of those bugs are being translocated. So you can measure that in terms of the amount of bacteria in the blood and the inflammation that it causes. So she gives Cipro, and lo and behold, everyone's bacterial load and inflammatory cytokines comes down. Okay, antibiotics decrease inflammation. So there's a battery of cognitive tests which underlie the sort of gold standard for finding the earliest stages of hepatic encephalopathy. And she finds that everyone's performance gets worse after she infuses ammonium salts, just like McDermott did. So here we go, ammonia hypothesis coming back. You give someone ammonia, their cognitive function on standardized paper pencil tests gets worse. But she does that same experiment again after the patient had received a couple of weeks of Cipro, and when she infuses that ammonia, no cognitive dysfunction is unlocked. So it is necessary for that ammonia to cross the blood-brain barrier to have a significant level of inflammation present. Now, Cipro is not an antibiotic I'm out there recommending that you give, but this is something that was pursued to the right degree by the investigators that established the FDA approval for rifaximin. So rifaximin will decrease peripheral ammonia levels and peripheral inflammatory markers. And you give patients who've had a history of hospitalization for hepatic encephalopathy rifaximin while they're taking lactulose, and you can reduce a second episode of hepatic encephalopathy by 50%. This is the trial that got FDA approval, and it's subsequently been validated in real-world studies, including my own, from that same quality improvement where we standardized the use of lactulose on the wards, and we showed that an automated reminder, as opposed to a checklist, and checklists never work, spoiler alert, an automated reminder to use rifaximin was able to reduce readmissions by 40%, adjusting for the suite of confounders that would be associated with repeated hospitalization. So the combined refined ammonia hypothesis of hepatic encephalopathy includes not only the ill effects of ammonia, but also one's global burden of glutamine and glutamine synthesis, as well as the necessary level of inflammation to lead to that transfer of ammonia across the blood-brain barrier. So those are the bad things that can happen to patients with HE and why. But I want to return back to this survival curve as we start to think about what we could potentially do to capture these patients before they show up in your emergency room. Because if we are able to figure out who is at risk for that hospitalization, we might be able to intervene with some relatively simple maneuvers that could potentially prevent a first episode of hepatic encephalopathy. It's important to recognize, of course, that HE exists on a spectrum. So we've been talking mainly about overt HE, the stuff of inpatient medicine that begins and ends with coma. But many people have deficits in cognitive function, executive function, they're bad with math, and so forth. That is what defines covert encephalopathy. And along that spectrum, each of the adverse outcomes of HE can be present, including poor quality of life, falls, car crashes, hospitalizations, and disability. And if you are able to find someone before they develop overt encephalopathy and define the presence of covert encephalopathy, you are finding a very high-risk group, as was shown in this very nice graph by Bajaj from Virginia, that if you are able to define that high-risk group based on the presence of cognitive dysfunction, you can find a group that's much more likely to die or require liver transplantation over time. So it's for this reason that my professional society recommends that we go looking for this, that we ought to define the presence of covert encephalopathy using one of these validated neurophysiologic or neuropsychometric tests using an experienced examiner. There's a few problems with this recommendation. One is that I work in a group of 16 transplant hepatologists, and none of us know of any experienced examiners for any of these tests. It's just simply not widely available. But there's other problems. One, it becomes obvious once you start looking at what these tests are. So some of the standard tests, these paper pencil tests, like along the lines of what Shawcross was doing, look a little bit like this. You ask a patient to trace a line in between two parallel lines. And you're standing there with a stopwatch trying to figure out how long it takes, but also you're counting the errors. So this is somebody who did a real good job. And this is somebody over here with asterixis. And you can see they're they're taking forever and they're bouncing in and out of the lines. So someone has to be trained to count each of these errors and how to and assign a total score for the patient at the end of the test. And then they have to go back to a bank of controls, healthy controls, matched for age and sex, and figure out where this patient lies on that spectrum. So if you don't have an experienced examiner and you don't have a bank of age and sex matched controls, then these tests aren't particularly useful for you. Fortunately, there's an app for that, and many of you may have heard of some of these, and I just want to review them for the purpose of education. All of these, two of these are developed by Bajaj in Virginia, and the one with the animals that I'll describe comes out of Europe. So this is something over here called the Encephalopathy, which can be downloaded on iTunes, and I challenge you to do it yourself before you ask a patient to, because I failed it. And what happens is you have to go through 5 runs of 10 of these flashing words and correctly tell the computer what the color of the word is. And the amount of time that it takes you to go through these runs correctly is supposed to be correlated with cognitive dysfunction. But you can tell it's kind of hard because you get this misdirection. The word is blue, but it's colored green. The second test that I like to bring up, which nobody uses, but I use it clinically, and this might be useful as you assign a gestalt about someone's risk for hepatic encephalopathy moving forward. It's questions that were derived out of a quality of life questionnaire, and it gets at what's happening to patients before they develop overt HE. They don't maintain their balance. They're irritable or impatient. They're not doing stuff that they think is fun, and they're eating much less than usual. And if you score positive on all of these things, you may have covert encephalopathy. Another test, which is very promising out of the dementia literature, is simply asking a patient, giving them a minute, and saying, how many animals do you know? And then you count how many animals they can tell you, and the number of animals that they tell you is associated with the presence of cognitive dysfunction as adjudicated by those standard neuropsychometric tests like the line tracing test. There's a few problems with this literature, and the reason why we're not using them as much as you'd think, given how many papers there are on them. One is that in order to produce these clean experiments about cognitive dysfunction, the investigators have systematically excluded all patients with comorbidities like CKD, CHF, COPD, all patients who are taking benzos, opiates, antipsychotics, and all patients who are actively drinking alcohol. Now, that turns out to be more than 50% of the contemporary patient with cirrhosis. So it's not clear that the results of these tests are going to apply to your patients. And the second question is, well, what is abnormal? Again, you're relating it back to a battery of cognitive tests which were derived from relative performance according to age and sex match controls in your area. And unfortunately, people's performance varies with the area that you're assessing them. So Bajaj himself found that controls in the state of Arkansas, if they were evaluated in the state of Virginia or Ohio, would be considered as having covert encephalopathy, a significant proportion. That's not besmirching the good name of people with Arkansas, but what it speaks to is some studies that I did with some other colleagues, which is to say that there are certain comorbidities which might be part of healthy controls, like obesity, diabetes, smoking, a remote history of alcohol use, which impact cognitive function. So we reviewed all of this in a systematic review where basically we said you got variable gold standards that we're using, and these are not representative populations, so we need to do a little bit better for these patients. Further complicating the story is the fact that not everybody proceeds through this spectrum in a linear fashion. You don't go from having no HE to covert HE and overt HE. Sometimes you're walking around with totally normal cognitive function, and the next thing you can show up in Mount Sinai West emergency room with a coma, because the trajectory of HE is incredibly unpredictable. So even in that graph that I showed you from Bajaj, where you had the red and blue lines, the blue line of people without cognitive dysfunction, they were still on the hook for these adverse events at a significantly high rate. So we're not simply capturing everybody who's at risk using these methods. So I would argue that there has to be a better way. And I stumbled onto this concept in a study that we did out of the VA. So at the VA, we have everybody in our grasp. We know everything about their medications. We know everything about what happens to them over the course of their life. And I can define them very well based on the lab tests that are available in our system. So I took everybody within the province of the VA where I work, VISN 10/11, and I found everybody that had cirrhosis and portal hypertension. So these are the people who are really at risk for HE. They have varices, ascites, or they have an APRI score AST to platelet ratio index greater than 2. And I exclude anybody with a history of HE based on a diagnosis code, or if they are ever touched lactulose, rifaximin, or any of the other antibiotics that might have been used to treat this condition. And then I followed them for up to 5 years. And I found that 40% will develop hepatic encephalopathy within 5 years, which is roughly in line with what other people find. And unsurprisingly, the severity of their liver disease is significantly associated with the development of encephalopathy. The use of non-selective beta blockers like carvedilol, nadolol, propranolol, these things do not cause HE, but they reflect clinically significant portal hypertension, and therefore that's associated with HE. And because statins are somehow a miracle drug in patients with cirrhosis, they're certainly safe, and in studies like this, they may have some protective effects. Statins are inversely associated with the presence of HE. So we did like what the Framingham risk score people did, is we took the regression coefficients from our Cox proportional hazards model, and we gave each of these factors a point system. And we could give a patient their risk over 5 years, and that may or may not be useful, but we could also give them their risk over 1 year, something that can be updated after a therapeutic intervention. If you stop drinking, if we cure your hep C, or if you start drinking, your labs will change, and with it, your risk of hepatic encephalopathy. So you can imagine a person shows up, compensated cirrhosis, labs looking good, they're working, but they have varices. So that's a person who's at 40% risk of developing HE over the ensuing 5 years. But in the next 1 year, that's a patient at very low risk for hepatic encephalopathy. So this is meaningful information that you can give to a patient. Another thing that I'm exploring, and I just want to throw this out there, is that frailty is an epiphenomenon of hepatic encephalopathy for many patients. And frailty is something that we can assess at the bedside, either clinically or by asking them to give us a hand grip or their walk speed. And we're actively exploring the role of using muscle strength, hand grip, walk speed as a way of predicting the development of hepatic encephalopathy. And that might be more applicable than these neuropsychometric tests, which have systematically excluded all patients, all contemporary patients with cirrhosis. So using this paradigm, I want to redefine that at-risk state. So it's not simply that you had no HE, then you developed covert HE, but you have risk factors for that HE. And those risk factors can be extrapolated from your clinical history, from administrative data. They include things like the presence of portal hypertension, liver dysfunction available in albumins and bilirubins, comorbid conditions, sarcopenia, which is what I'm actively measuring, and psychoactive medications. If the neurologic lesion of hepatic encephalopathy is increased GABAergic tone, what is the risk of hepatic encephalopathy in someone on gabapentin, someone taking benzodiazepines? These are things that have, these are druggable targets, but only in this case, we're de-prescribing those medications. So in sum, the so what is that once you have thought about someone's risk of hepatic encephalopathy, you can relatively efficiently address that risk by telling them about the right diet, about protein and when to eat it. You can assess their fall risk and potentially refer them for physical therapy or give them some YouTube videos that might help with strengthening exercises. If they're taking benzos and gabapentin and you have an alternative, by all means, get them off of those medications. And if you think that they're at risk for encephalopathy, then they probably shouldn't be driving, or you should consider a driving fitness test. So we started with many scripts to flip, and I hope you'll agree that we've accomplished a mission. One is that HE is important and has an outsized impact on American public health. Two, if you meet a patient with hepatic encephalopathy, think about the difference between induction dosing of lactulose and maintenance dosing. You want that patient to wake up as fast as possible and get out of the hospital before a nosocomial complication should arise. We think about the ammonia hypothesis, but refine it for the presence of the other factors which contribute to its toxicity. And rather than starving our patients, we're starting high-protein diets. And we are thinking about who's at risk for hepatic encephalopathy so that we can initiate the simple treatments that could be effective in preventing patient harms. Thank you very much.
Thank you very much. You know, as a neurologist, I really appreciate this lecture because I think this is one of those metabolic encephalopathies that frequently goes unrecognized in the early stages with frequently disastrous results. I would point out that the co-author on McDermott's paper went on to become one of the most famous neurologists in the United States, Ray Adams. Having come from the era when a low-protein diet was standard therapy, pre-lactulose, one of the clinical challenges that was used in the 1950s was to take a patient who suspected of episodic hepatic encephalopathy, do a baseline EEG, and then give 2 milligrams of morphine. And these patients are incredibly sensitive to opioids. And in fact, if you have a patient who seems to have an excessive reaction to an opioid, this was one of the considerations. And I would only point out that EEG does remain an extremely sensitive test for early hepatic encephalopathy. You may not get the classic prophasic waves, but you certainly will see the slowing that indicates some form of metabolic encephalopathy.
Thank you very much. I obviously agree with both of those points in highlighting the role of opiate deprescribing as well.
Very excellent presentation, Dr. Zapper. I was wondering whether or not you could actually comment on the societal impact of hepatic encephalopathy.
Yeah, so one of the things that I didn't get to talk about is that not only does hepatic encephalopathy rob a patient of their productivity, but it begins to exert a profound drag on those around them. So their caregivers report incredible burden. Both their quality of life is decreased, and a significant proportion, depending on the survey, as many as 20 to 30%, will actually lose their job as they begin to take care of their patient, of their loved one with hepatic encephalopathy. So there are many unmeasured impacts of hepatic encephalopathy beyond simply the patients that you're caring for.
Elliot, that was a terrific talk. Mike Smith, Chief of GI and Hepatology. We're really glad to have had you here and to share your wisdom. Wondering if you could talk to us a little bit about how to manage lactulose belly, the distension associated with giving lactulose and the patient effects. Do you have any tips and tricks for that? And as a transplant hepatologist, I know that there are several transplant surgeons that try and take the patients off of lactulose if a transplant is imminent to try and minimize the distension and have to go and put everything back together. And so both in the patients admitted with HE and those who are aiming towards transplant, how do you manage that distension?
Yeah, so that is a really that's a really tricky part of lactulose, is that the displeasure that's associated with it. So there's a couple of ways that we get around that. One is that you can provide empathic support, and sometimes that will get you through. Two, we sometimes try the packet or crystallose versions of lactulose, and I'm not sure why that would be less associated with bloating and discomfort, but it often is, and virtually all of our patients love it. We just have trouble getting approval for it. And then sometimes we try adding antibiotic like rifaximin in hoping that it helps with that. But it's a very vexing problem. I don't offer any great solutions for it. In general, the important thing to remember is that although lactulose is not awesome, we're not voluntarily taking it ourselves, and although we probably should just to see what it's like, it is overall in randomized trials associated with improved quality of life. because of the deleterious effects that it's preventing. So I don't want to minimize those patients' concerns. Those are my maneuvers, but I don't offer anything that you probably haven't thought of.
Where does the gas come from? But separate from that, are there any differences between the causes of cirrhosis and the response to treatment? I know that alcohol is a major culprit, but hepatitis, toxic hepatitis, is there any difference between them?
Well, I think the short answer for that question is that there's probably no difference in the various etiologies of liver disease. However, in a lot of our studies on cognitive dysfunction, patients with significant alcoholic liver disease, active drinking, have been excluded. And it's true that alcohol will cause many of the signs of cognitive dysfunction that one could attribute to hepatic encephalopathy. And it's also true that some of the most refractory cases of hepatic encephalopathy that I have experienced and others report are in patients with NASH. And this also speaks to some of the comorbidities, the microvascular comorbidities that accompany patients with NASH. It may make them they may have less reserve and are more brittle to the given impact of hyperammonemia and inflammation. But the response to lactulose in the wards is always going to be invariable. But the rate of relapse, I say anecdotally, is probably different. The problem is that we've excluded the patients at highest risk of organic brain disease from alcohol from study. And then two, we really don't know much about the natural history of decompensated NASH cirrhosis simply because those stories haven't been written.
Thank you.
One more question. Could you be a little more specific about how you coordinate these two medicines? Lactulose, often I find that the patient will take the lactulose, everybody says they're better, and then they stop because of the distension. That often happens. But what about using an antibiotic, and when, and together, right away? And how is this coordinated? Is it different with NASH than it is with alcoholic hepatitis?
Yeah, so it's a very good question about the timing. So the FDA approved rifaximin on the basis of secondary prevention, and that's basically what the guidelines re-emphasize, that if you've had an episode of overt encephalopathy, you should start rifaximin. And many people start it if they've shown up in the hospital with it. But if you're about to start a treatment for hepatic encephalopathy, then that must be accompanied by appropriate education about how long and the duration of treatment, and they have to understand what goes into preventing an episode. And this often involves talking to the caregiver, making sure that they're on track with you, so that they know that if someone is becoming more confused, that they should give them more lactulose at home. I would say. I just one thing that I've come up with, that I've encountered in my time, is these patients with refractory HE, simply driving to see you in clinic can provoke an episode of encephalopathy because they have to time their bowel movements so carefully. You can imagine taking the train, driving long distances from northern Michigan and so forth. And so I've actually adopted a practice of using video visits for patients with hepatic encephalopathy to maintain their schedule as best I can.
Thank you, Dr. Tapper, for a great talk. Look forward to more tutorials in the future. Just wanted to know, we heard reports about increased risk of hepatic encephalopathy in patients on PPIs. So just want to know what's your practice when you see patients in your clinic who have been prescribed PPIs and are at risk for hepatic encephalopathy. Do you de-prescribe, or is the data strong enough to de-prescribe, or do you have to weigh the risks and balances?
Yes, that's a fantastic question, and it gets at this sort of package of de-prescription that patients with cirrhosis must undergo if they're being seen by if they're being seen in clinic. So a PPI is not indicated to prevent a variceal bleed. And many patients are started on PPI for variceal bleed, for which there is absolutely no role for PPI. And if you find that this patient does not have disabling GERD that can't be managed with PRN and Maalox, then you get them off of that PPI. It's very straightforward. A PPI is associated with overacute HE in a host of confounded studies from around the world, but Bajaj has shown that when you stop PPI, there's observable differences in the microbiome which are correlated with reduced risk of hepatic encephalopathy. I do not believe that you'll ever see high-level evidence to support deprescription of PPIs or the toxic effect of PPIs, but once you know that a patient is unlikely to benefit from a PPI, and some people do benefit from PPI. If they had life-threatening hemorrhage from an ulcer, by all means. If they have disabling GERD, by all means, continue the PPI. But if there's a reason to stop it, then I do it, and I always find a way. Okay, so basically, there is no real dose of lactulose, and you start out with something that you've chosen out of thin air, like 20 grams TID, just if you have a stable patient. But if they're not having any bowel movements, then they have to increase that dose. So I have patients with motility disorders because of Parkinson's, and they're taking essentially a bucket of lactulose a day to have 2 to 3 bowel movements. And I have patients who have significant diarrhea after more than a tablespoon of lactulose. So you ultimately have to find that accommodation for the patient. Now, I am certainly not worried about a bowel complication from lactulose, but if you are flooding someone with lactulose and they're having excessive diarrhea, and in that diarrhea there's a ton of electrolytes, then they are at risk for things like sodium and potassium abnormalities. If they're in the hospital, you're following those things, and then you can equilibrate by reducing the dose of lactulose. But in the upfront setting, your goal is to achieve laxation immediately, and there is no maximum dose. So I start with 20 grams. I load people up with 60 grams of lactulose, and then I follow them every hour until they've had a bowel movement or they've woken up. And that's what we do. We never get into hyponatremia. It's simply not possible if you're watching a patient and you're doing these things within the course of a couple hours. But if you are flooding someone with lactulose and then walking away and never checking a lab, you could get into trouble.
I want to thank you very much for this very important topic and presentation, which was excellently done. Thank you very much.